Bonjour les amis, alors une vidéo à ne surtout pas rater avec le docteur Makis et le docteur John Campbell sur les turbo-cancers.
In recent years, have you seen an increase in aggressive cancers, higher grade cancers, cancers affecting younger people, what is sometimes called turbo cancer? And is that a term you like?
I have seen this, honestly, and I first saw this phenomenon in 2022. That was when I first realized there's something else going on since the start of the pandemic that hadn't been properly characterized or looked at. I saw it among my colleagues, physician colleagues, who were coming down, young colleagues who were coming down with these extremely aggressive cancers, and cancers that behaved unlike anything I had seen before. And I have seen that since. I've seen that in nursing. I've seen that among teachers. These various professions that faced mandates at some point. And I'd seen this phenomenon, these very aggressive cancers, and they would kill the person very quickly. They would kill a person in a matter of 6 months. And so the behavior was very different. I alerted the Canadian Medical Association of this in September of 2022. I had alerted them that I had seen a number of my physicians' colleagues come down with these extremely aggressive cancers, and the term turbo cancer started to be used around that time as well. It's not a term I like. I don't like the term turbo cancer. It's not a medical term, and it's a term that someone who's sort of not aware of this phenomenon of these aggressive cancers may not take seriously. It's a term that doesn't sound professional, but it's a term that I think really appropriately describes what I believe is a brand new phenomenon in cancer, which is that some people are now developing extremely aggressive cancers that present at stage 4. Usually, we're not catching them early on, we're catching them quite late. Stage 3, stage 4 presentations. Young people, these are shocking. When you see young women in their 20s present with stage 4 breast cancer and they have no family history and they have no genetic markers that you can detect, no BRCA1 or 2 mutation, that's when you realize that something is really wrong here. Colon cancers presenting in young people in their 20s and 30s, we shouldn't be seeing that. I always refer to the case of cholangiocarcinomas. These are bile duct cancers where the average age was 70. The average age of presentation. This is a cancer of the elderly, and yet we have 20, 25-year-olds presenting with stage 4 cholangiocarcinoma, something that I'd never seen in my career. And so there is something new happening. The term turbo cancer has stuck. I believe it appropriately describes the very aggressive nature of these cancers. They grow very rapidly, they metastasize and spread. So even when surgeons are trying to go in and get the primary tumor out, by the time they rescan the patient after the surgery, they realize it has already spread to multiple organs and they didn't catch it in time. That's how quickly this thing moves. And one particular feature of it, which I think is very shocking but very characteristic, is these cancers are resistant to conventional chemotherapy, conventional radiotherapy, and even conventional immunotherapy. And so you see this very shocking resistance to chemotherapy. And so you will get either no response or partial response. The oncologists really struggle with these cancers, these turbo cancers. They struggle with them because they throw everything at it. The oncologists are genuinely trying to get these cancers under control as they used to in the past. And so imagine, you would have a breast cancer patient who could live another 5 years, 10 years with conventional treatment. And then that patient dies 6 months later. And you're left wondering, what is going on? Why are these patients dying so soon after diagnosis? Why are they resistant to conventional treatment? And that's just not being looked at. It's not being studied. It's really being ignored by mainstream oncology. And so Professor Daglish, for example, talks about this.
Yes.
He has noticed this phenomenon in the last few years as well. And the pathologists, I'm really proud of my pathology colleagues like Dr. Ryan Cole, Professor Burkhardt in Germany, who've really been, raising the alarm about this, telling us there is something wrong here. These turbo cancers are real, and they are claiming thousands of young lives, and no one is studying it. No one is looking into it.
It almost sounds like a new pathology, doesn't it? I mean, tragically in clinical practice, we've seen young cancers, we've seen childhood cancers, but very often young adult cancers are associated with a specific mutation or genetic disorder. You mentioned there the BRCA1 or 2 mutation, which predisposes to tragically early life breast cancer, ovarian cancer. But now we're seeing cancers of an aggressive nature in young people without these genetic mutations.
That's right.
It's almost like a new pathology, and the fact that they seem to be resistant to existing treatments, again, is indicating a new pathology, really. I want to talk about that a bit, but just before that, you mentioned stage 3 and 4 there. We talk about this a lot. Just run us very briefly through, if you don't mind. What is stage 1, 2, 3, 4 cancer?
Well, so the stages represent really the size and extent of the tumors. And so if we take breast cancer as an example, stage 1 would be a small tumor, 1 centimeter, 2 centimeter. Then stage 2 would be a larger tumor. And then usually you often have spread to local lymph nodes. And then that'll be stage 2. Stage 3, you might get spread to further lymph nodes. It's now you're not in the local area of the tumor anymore. You start spreading to more distant lymph nodes. And then stage 4, of course, you get spread to other organs like liver, bones, brain, and so on. And so each cancer has its own staging system, stages 1 to 4, that describe the size of the primary tumor and the spread to the surrounding. It starts, usually spread to surrounding lymph nodes and then eventually spread to other organs as well.
But when we talk about stage 4, we're talking about metastatic disease. There'll be the cancer will be in the primary site. It'll probably have grown and expanded in the primary site, but it'll have metastasized, spread to distant parts, one or more distant parts of the body, making it much harder to treat, presumably.
Exactly. And I think I want to go back to this idea, and you'd mentioned that it almost looks like a new pathology.
Please.
And I do believe that we are dealing with a brand new pathophysiology. We're not dealing with just cancers that are more aggressive. We're dealing with something brand new, something that has a new mechanism by which it's arising. And I believe, again, this is where the pathologists come in, like Dr. Ryan Cole, Professor Burkhardt, where they're trying to look at these tumors and see what's different about these tumors, what's different about the patients who develop these cancers. And so we are dealing with something new. And another marker or another feature of these turbo cancers that I find fascinating that has come up over and over, and really no one talks about it, is that oncologists tend to be very good at giving you a proper prognosis. And so when you come in and you're a certain type of breast cancer patient, let's say stage 4, we know that you are, hormone positive, for example, the oncologist is very good at giving you a prognosis, saying, look, if you follow, the conventional treatments, we know you're going to live another 5 years or 10 years or 3 years, whatever the case may be. And so the prognostication in oncology is quite good. My oncology colleagues are really quite good. And this is based on studies of hundreds of thousands of people. Usually these are the large trials that they look at when they offer conventional treatments to patients. Well, this is where they've been completely off. And you will see this thousands of cases on GoFundMe where families of cancer patients are raising funds, and they will share the medical story of the person who's been affected by a turbo cancer. And they will say, the oncologist told us we had 5 years and our loved one died within 2-3 months. I have never seen my oncology colleagues be off by a factor of 10 in prognostication. I have never seen that. You don't get it that wrong. Or colon cancer, for example, where you could live another 5 years and then the person again dies 2-3 months later after diagnosis, and it catches the oncologists off guard. It catches the family off guard because they've told the family, we can, with conventional treatments, you'll have at least another 2 years, 3 years, 5 years, and the person dies a few months later. That shocks everybody, and that throws everybody off. And so why are my colleagues now off in their prognostication by a factor of 5 to 10, there's something wrong here. I believe we are dealing with a brand new pathophysiology. I believe it's something that should be seriously looked at. And unfortunately, we're stuck in the situation where some of my colleagues who are seeing this, like Professor Daglish, for example, we will look at the literature. We will look at the published literature and understand that there are dozens of papers that are looking at aggressive cancers and the manner by which they may be arising, and there are case reports and so on. And yet, on the other hand, when you'll have doctors in the mainstream and in academia saying, well, there's no such thing as turbo cancer, and when you put it in the search engine, no literature comes up. And you have Wikipedia, which will say turbo cancer is a conspiracy theory, it's a alternative medicine, fringe medicine. It doesn't exist, right? It's not a thing. It doesn't exist, and that's not science. That's not science. When you have a phenomenon in front of you, to say this doesn't exist, this is not happening, and this is not real, and cancers are not increased, and cancers are unchanged. To deny a phenomenon, that's right in front of your face, and where you have thousands of cases with families coming to social media saying, yes, this happened to us, that's not science. That's not how science should work.
It is quite bizarre, isn't it? It is denial of that which is patently obvious. It's a bit like saying Australia doesn't exist. I mean, it's, we're into the realms of incredulity here, really. It's so you mentioned these accelerated cancers, turbo cancers, for want of a better term. Are we seeing like a group of turbo cancers and a group of what you might call traditional cancers as well? So are we seeing a group of cancers that still carried on where the oncologists are still getting it right?
Absolutely.
So we kind of get two streams of cancers, really.
Exactly. And so I see both. I see both. I see your typical cancers where a patient has been struggling with stage 4 breast cancer, and they've been struggling for years. But they go to various chemotherapies and immunotherapies, and they're effective for a while, and then at some point, they're not effective anymore. They get a bit of progression of disease, but they've had stage 4 for 4 or 5 years, and they're still battling it. And then you have a similar situation where a stage 4 breast cancer patient will come in, this cancer is growing extremely rapidly. Nothing seems to work. Anything that the oncologists tried, nothing seems to be working, and then they pass away after a few months. And so both of these are going on at the same time. And it is confusing. I think if you're not open to the idea that something has changed in the last few years, where we might be seeing a brand new pathophysiology, whatever the reason behind it may be, if you're not open to the idea that something has drastically changed in the last few years, where you have this subset of cancers that are behaving completely differently, then I think you will be caught. If you're in medicine and you're not open to this, I think you'll be completely caught off guard.
Which seems to be happening on a huge scale, I think it has to be said at the moment. Now, what sort of, if we use this reluctantly use this term turbo cancer, what sort of primary sites are we seeing? Where are these cancers originating? And is there a typical sort of metastatic pattern? So, for example, in the colon, you would expect it to go to the liver. If the prostate, you might expect it to go to the bone. So, first of all, what sort of primary sites are we seeing with what we could call turbo cancers?
There have been articles published. I believe there was one published by Memorial Sloan Kettering Cancer Center in the United States that talked about a wide variety of cancers that have sort of exploded recently and are affecting young people. So it's not one type of cancer, one or two types of cancer. I'm seeing an explosion of lymphomas, brain cancers that are even more aggressive than what we were used to in the past. Breast cancers, the big ones are breast and colon. And I can tell you, in fact, how the mainstream medicine and oncology are reacting to this explosion of breast cancers and colon cancers in a much younger cohort. And so I do believe that this new pathophysiology affects all ages, but when you see it in a younger cohort, people in their 20s and 30s, that's when you say, wait a minute, something's really, really wrong here. This is not a cohort that should be presenting with stage 4 breast cancers or colon cancers. And so far, the response of of mainstream oncology has been to lower the screening age. And so we've seen this in the United States, and we've seen this in Canada, and I don't know about the UK, to be honest, but the screening age for breast cancer has already been lowered from 50 to 40.
Not as far as I'm aware in the UK, but it's interesting that's happening in the States and Canada. That
has already happened. The screening age has been lowered for breast cancer from 50 to 40 for mammography. And now there's significant debate going on about decreasing the screening age for colon cancer. And then the debate is, well, what age are we lowering it to? Are we lowering it from 50 to 40 or even to 30, to have that?
Yeah, it's still 60 in the UK for fecal occult blood screening.
And again, this doesn't get a lot of attention, or it doesn't get a lot of media attention, because I think the cancer centers themselves can't make, they don't know what to make of this situation with these turbo cancers. And so they talk about lowering the screening age, but we should be finding out what the pathophysiology is behind these cancers. We should be looking at these cases specifically. We should be analyzing them. I mean, pathology is the specialty, that could look at these tumors in detail, analyze them, and see what is different about these tumors that is causing such a rapid progression and such poor prognosis.
Well, that's why we have pathologists. That's why they're useful people to have to do pathology. It's fairly obvious. So, I mean, I take your point there entirely. So, 72-year-old woman gets turbo cancer of the breast. Breast cancer is common at that age anyway. 22-year-old woman, it kind of stands out. It's more of an obvious outlier, but you believe it's occurring at all ages.
I do see it in all ages, exactly. And you're absolutely right. When it happens in someone who's in their 60s, 70s, 80s, you don't pay as much attention to it. And you say, well, cancer is much more common in these age groups, and it doesn't catch your attention. It doesn't stand out. And yet when you see a 20-year-old, and I've seen women as young as 18, 19 presenting with stage 4 breast cancer with no family history and no genetic markers to go on. And if that isn't a red flag or an alarm bell for the medical community and for oncologists, I don't know what is. I mean, that
is unheard of, unless you're in a post-Hiroshima situation. It's just unheard of, isn't it? It just doesn't happen.
Absolutely.
Yeah. Now, I want to think about temporal correlations. You started noticing this early 2022. So, what possible changes could there have been in the environment in the years before that, and what do you suspect the lag period might be? So, for example, we had COVID in 2020, we had COVID vaccines in 2021. If we postulate that this is a post-COVID, post-vaccine event, do you think that 1 or 2 years is a significant lead time for the pathological changes induced potentially by COVID infection or by vaccination? Is that enough for that to transpose into the overt pathologies that you're seeing?
Well, I think this is where I think the discussion gets quite heated, because you will have people saying, well, if someone develops an extremely aggressive cancer, maybe they had a COVID infection a few months before, maybe they had a vaccination, and you will have people saying, well, that's not enough time, for an aggressive colon cancer to arise. A colon cancer takes many years to develop, or even a breast cancer, and yet I am seeing some of these temporal correlations in some cases, but in some cases, this cancer will arise years later, and so there's not a clear picture of a temporal correlation. But you bring up the point. Well, what has changed in the last few years that could be contributing to this, to this dramatic rise and this potentially new pathophysiology? And I really think you've got these two main things that have happened in the last 4 or 5 years. Is we have this COVID virus, this somewhat novel virus. And we had a pandemic with multiple waves of infections. This is not a one-time thing where you could say, well, we had one wave of COVID-19, we've had multiple waves, unfortunately. We've had different variants. We've had Delta variant, the various Omicron variants, and then also we've had the COVID-19 vaccines and different types as well. We had the DNA-based vaccines, we had the mRNA-based vaccines, and so these are things that are different, that have affected a large segment of the population in one way or another in the last 4 years, let's say. And so I think it's worth looking at those things. But it seems to be somewhat of a taboo subject, particularly because there's this overall desire of people to just move on. People want to move on from the COVID pandemic, and they don't want to talk about what's happened in the last few years. But I really noticed this phenomenon in 2022, in the summer of 2022, but I could trace back some of these extremely aggressive cancers to 2021 as well. And when some of my colleagues were being diagnosed with these extremely aggressive cancers, these turbo cancers in 2021, and really no one realized that there was anything different about these cancers, and they would die 6 months later, and people would say, well, that's unfortunate. You had bad luck. It's okay. Well, you could have bad luck in a few cases, but when it's happening, when you have thousands of cases of bad luck, that's when science has to come in. That's when you have to investigate, and you have to investigate with an open mind. You have to look at all the possibilities. Could there be something from a COVID infection that might be contributing? It's very possible. Could it be something from the COVID vaccine? That's also very possible as well. We have to approach this with an open mind and look at those possibilities. And yet, those of us who are raising the concerns, raising the questions, we get attacked, we get censored. I was censored for about a year off the Twitter platform. I only started my Substack, where I published a lot of articles talking about this phenomenon. I started my Substack in early 2023 because I wasn't being allowed back on the Twitter platform. I thought I would never get my Twitter account back. And fortunately, Elon Musk bought the entire platform for $44 billion and brought a number of us, physicians back, like Dr. Robert Malone, Dr. Peter McCullough, Dr. Pierre Corey, and Dr. Ryan Cole, and so on.
Donald Trump.
Exactly. So
others that could be mentioned.
I feel blessed and fortunate to have my voice back, because in 2022, when I was raising these concerns, I was writing letters to the Canadian Medical Association. I was being ignored. I didn't have a social media platform. So I was effectively censored during a time when I was trying to raise concerns about turbo cancer, about this new pathophysiology that was affecting people, these stage 4 cancers that no one can quite explain why they behave the way they behave. I didn't have a platform. I was completely censored at the time.
You were being censored at the time we most needed people with your expertise and your background. It really is quite paradoxical and bizarre. My simplified way of looking at this, if there is a new pathophysiology here, then it's not unreasonable to say that there could be an accelerated oncogenesis, an accelerated development of cancer. I mean, very often with cancer, we think about a long progression. There might be changes in tissue, so-called metaplasia, before the malignant change. There might be multi-hit ideas.
Exactly.
If we're dealing with what we might call a complete carcinogen, an initiator and a promoter that can do both things really quite quickly, it's not ludicrous to me at all that someone could have no pathophysiological changes, no anatomical changes, be exposed to an initiator and promoter of cancer, and develop clinical pathology within a year. I find that quite credible, but based on my limited experience, understanding of the pathology.
Absolutely. So that's definitely, I think, a component of this. Another component that I think is relevant is the state of a person's immune system.
Yes.
And so, when we have something that impacts a person's immune system dramatically. Now we see this in AIDS and HIV patients who have HIV infections. They develop some very aggressive cancers because their immune system is compromised. And I think, again, we've been in a situation in the last 4 years where people's immune systems have been compromised, whether they were compromised by a virus or a vaccine. I think we see a lot of people who are struggling with infections. They get repeated infections. They get repeated COVID infections, or they may get repeated influenza infections. I have seen an explosion of strep. I have seen an explosion of sepsis. And young, healthy people dying of these things, young, healthy people dying of influenza, young, healthy people dying of strep throat and septicemia and septic shock. And so I do believe that a compromised immune system, may play a role in some of these cases. And we don't have a good way of measuring a compromised immune system. So someone whose immune system has been damaged in some way, we don't have a great way of measuring it. We measure the CD8 and CD4 cells in AIDS patients.
The white blood cell profile.
Exactly. But we don't have a good way of measuring, if someone's immune system has been compromised in some way. And so I think that also plays a factor in some of these cases.
I suspect personally that the coronavirus was not the cause of these turbo cancers, because we've been exposed to different coronaviruses for a long time. Okay, this one was quite novel. It had some unusual features that are difficult to explain. There's no obvious predecessor in the natural world for this particular one, but at the end of the day, it's still a coronavirus. And the small components of that, the bits that the immune system recognises, what we call the epitopes of that, a lot of those would already be somewhat familiar to the immune system. So I suspect we're looking at something other than the coronavirus that occurred in 2021. That seems to be the Occam's razor, if you like.
I think so, and I think and the other part of it is also looking at populations that are affected. I see university students, college students who've been impacted by turbo cancers. I've seen certain professions, doctors, nurses, teachers, police officers, firefighters, military, and so you have to ask the question, well, why are we seeing this in certain groups? There were mandates in some of these groups, especially in 2021. We had mandates that affected a lot of these people, a lot of young people, or some of these professions in healthcare, for example. We had healthcare workers who faced mandates as well, and the entire profession faced it. So I think it's definitely something that we have to look at and really consider a possibility where there were mandates. Is that something that contributed to this phenomenon?
To understand that, we really need full data release and release of primary source data that in the UK at least we simply don't have access to. So I'm optimistic that in the United States this data can be made available. Now, I've talked to people who know about this and they assure me categorically that this data can be completely anonymized and yet is amenable to very rigorous quantitative analysis. So, and when we're dealing with millions of people.
Yes, we have that opportunity in the United States.
Yes.
I don't see this opportunity in Canada, for example. I know
nor
that
in the UK.
That the government, there's been no transparency from whether it is the federal government or the provincial governments that are responsible for healthcare. If anything, I had actually started my Substack with a series of articles on how the government was deleting data, crucial data from the government websites, where people could no longer make an informed decision in terms of their own personal health, because the government was either hiding or deleting data outright. So I think there's a very unique opportunity now in the United States with RFK Jr. Being confirmed, which I believe he will be confirmed, and I think he's expressed a strong desire to to look into this, and really a strong desire for transparency in science. And that's what we need. We need transparency in science to do proper science.
Across the whole field, this is just one particular example, really, but let's hope there's been no data accidentally deleted in the United States in the past few weeks. Let's hope that is the case. Dr. Makis, that's absolutely fascinating. I've let that run a while to unpack that. I think that's really well worth doing. Absolutely important to document that.
Cette vidéo est informative. Je ne veux absolument pas, je ne souhaite pas être censuré par YouTube. Je ne fais que transmettre des informations que nous donnent deux prestigieux docteurs, le docteur John Campbell et le docteur William Makis, sans prendre parti, sans dire qui est le responsable de ces turbo-cancers. Vous écoutez et vous faites votre choix et vous prenez ce que vous pensez avoir écouté. Est-ce que c'est la vérité? Est-ce que c'est pas la vérité? Je n'en sais rien, je ne prends pas parti. Attention, YouTube ne me sanctionne pas parce que cette vidéo est vue déjà par des centaines de milliers de personnes dans les deux vidéos que John Campbell a fait, et j'espère que ce ne sera pas comme la vidéo de John Axe et qu'elle ne sera pas supprimée de ma chaîne. De toute façon, je la publie aussi sur x.com/cancerthérapie1. Merci les amis, une excellente journée. Au revoir.